You take the pill every morning. You have taken it for years. The organizer is already open by the time the coffee starts. Your numbers come back fine at every appointment. 130/78, 128/80. And the doctor nods. The prescription gets refilled. And nobody mentions the one thing your body has been trying to show you every single morning. Take a look tomorrow morning at what happens after the first flush of the day. Not the water going down, what stays behind on the surface. If there is a layer of small, tight bubbles that lingers, the kind of foam that sits like a head on a beer and does not clear after a minute, pay attention. That foam is one of the earliest visible signs of something the medical system is supposed to be watching for in every adult over 65 on a blood pressure medication, and in the vast majority of cases, isn't. You have been taking the pill for years. Lisinopril, amlodipine, losartan, maybe two of them together. Your numbers look good at every appointment. 130/78, 128/80. The nurse writes it down, the doctor nods, the prescription gets refilled, and you go home. Meanwhile, in a study of more than 3 million adults across 44 countries, only 4 out of every 100 people being treated for high blood pressure had ever received the one simple urine test that catches kidney damage before it shows up in a blood panel. 4 out of 100. And when researchers modeled the untested population, they estimated nearly 20 hidden cases for every one that doctors were actually finding. 20 hidden, 1 found. Not because the test is expensive, because in a 15-minute appointment, the standard blood work gets ordered, and the standard blood work does not include it. This is the piece nobody explained to you when you started the pill. Inside aging exists for one reason: to explain what your kidneys have been trying to tell you, in plain language, before the damage becomes permanent. Coming up are the 5 things adults over 65 on a blood pressure pill are almost never told. Number 1 is the reason your doctor should be ordering a completely different urine test than the one on your standard panel, and it is the piece I want you to remember above everything else. But first, something you can do tomorrow morning. Because I want you to have a piece of information about your own body before we go any further. The foam check. First urination of the day. Look at the water for 5 seconds before you flush. What you are ignoring is the light bubbles that appear and vanish within 10 to 15 seconds. That is normal turbulence. What matters is what happens after those bubbles clear. If a layer of small, tight bubbles stays on the surface longer than a minute, that is a recognition sign researchers associate with albumin, a blood protein, leaking through the kidney's filters and into the urine. It is not a diagnosis. It does not replace a lab test. But it is a physical, observable clue that your kidney's filter may not be holding on to what it is supposed to hold on to. Post what you see in the comments. Type clear if no foam persists. Type some foam that cleared if bubbles appeared but faded within a minute. Type persistent foam if the bubbles held. If this is landing, hit the like button once. When you do, YouTube shows this to thousands of other adults over 65, quietly taking the same pill and never told any of this. Someone in your life could get the right test at their next appointment because of that tap. And if you want more of these, subscribe. Every week, Inside Aging goes through research your doctor does not have time to explain. Everyone is built around what you actually need to know. Now, let me tell you about a case pattern that shows up over and over again in the primary care nephrology literature. This is not a personal patient of anyone at Inside Aging. It is a pattern documented repeatedly in published clinical reports and consult records. We will call him Robert. Robert is 68, retired postal worker. Started lisinopril at 60 for high blood pressure. His numbers have been beautiful ever since. 130/78 at every appointment. His creatinine, the standard blood marker of kidney function, sits at 1.1, sometimes 1.2. His doctor tells him every year that his kidneys look great. At age 66, Robert notices his urine is foamy in the morning. He assumes he is dehydrated. He drinks more water. The foam is still there. At age 67, his back starts giving him trouble. He does what a lot of adults over 65 do. He starts taking ibuprofen. 2 in the morning, 2 in the evening. Every day. He does not tell his doctor because it is over the counter. He does not think of it as a real medication. 6 months later, at a routine appointment, his creatinine jumps from 1.2 to 1.9. His doctor, alarmed, finally orders the urine albumin-to-creatinine ratio for the first time in 8 years of treatment. The result comes back at 480 milligrams per gram. Normal is under 30. Anything over 300 is severe. 2 things happened to Robert. His kidneys had been quietly leaking protein for years while the cuff and the creatinine both read normal. Hypertension was slowly damaging the filtering mesh, and the standard blood test was not sensitive enough to catch it. Then, when he added daily ibuprofen to his lisinopril, he triggered what researchers call the triple whammy, a combination that starves the very blood vessels feeding the filter. Add a water pill to the mix, and the risk multiplies further. Robert stopped the ibuprofen. His creatinine came partway down. His albumin level came down to 180, better than 480, nowhere near normal. The years of quiet leaking before anyone thought to test him are not fully recoverable. Robert's story is not rare. It is one of the most common patterns in nephrology consult clinics. Please talk to your doctor before starting or stopping any medication in this video, and before starting any over-the-counter painkiller if you are already on a blood pressure pill. So how does this happen? How does damage progress for years while every number on the page looks fine? Here is the mechanism, in one image. Imagine a coffee filter. Your kidney has about 1 million of them, microscopic filters, each the size of a grain of rice. Blood flows in one side, gets cleaned, and exits the other. The pressure inside that filter determines how much stress the paper is under. Too much pressure for too long, and tiny holes tear in the mesh. Protein leaks through. That is what shows up in the urine. That is what causes the foam. Lisinopril and losartan release the pressure inside the filter. That is their signature action. They protect the paper. In the renal trial of over 1,500 patients with diabetes and kidney disease, losartan reduced the risk of doubling serum creatinine or reaching kidney failure by 16% compared to placebo. Amlodipine lowers blood pressure everywhere in the body, which is why the cuff reads a good number, but it does not release the pressure inside the filter the same way. That is not a reason to stop taking it if your doctor prescribed it. Amlodipine is an effective drug. It has saved a lot of lives. What it is not, by itself, is a kidney protection drug the way ACE inhibitors and ARBs are. Which means, if you are on amlodipine alone after 65 and you have never had the urine albumin test, you are the highest priority conversation in this video. Here is the piece most patients never hear. Your kidneys can lose 30 to 50% of their filtering capacity before creatinine, the standard blood test on every panel, moves out of the normal range. Kidney mass drops roughly 10% per decade after age 30. Creatinine is a late marker. The urine albumin test is an early marker. Albumin leaks into the urine years, sometimes a decade, before creatinine moves. That is the biology of it. Which is why almost everything most patients believe about blood pressure medications and kidney health falls apart under this lens. Let me walk through the 3 most common ones. Myth 1. If my blood pressure is controlled, my kidneys are safe. False. Control on paper is not the same as protection at the filter. The urine test is what tells you whether the kidney itself is still leaking while the cuff reads fine. That distinction is one most patients never hear. Myth 2. A normal creatinine means my kidneys are fine. Not quite. Creatinine can stay in the normal range until 1/3 to 1/2 of your filtering capacity is already gone. Albumin in the urine appears years earlier. The 2 tests, taken together, tell the truth in a way that either one alone cannot. Myth 3. My creatinine went up when I started the ACE inhibitor. The pill must be damaging my kidneys. Usually the opposite is true. A rise of up to 30% in the first 2 months after starting lisinopril or losartan is expected. It reflects the pressure inside the filter dropping, exactly what the drug is supposed to do. A UK study of over 122,000 patients found that stable rises of that size were associated with better long-term kidney survival, not worse. The problem is not the rise. The problem is when the rise is misread and the drug is pulled, because then the kidney loses the very protection it was gaining. Here is what that means for you specifically. Now, the 5 things adults over 65 on a blood pressure pill are almost never told. Counted down from 5 to 1. Number 1 is the piece I want you to remember above everything else. Number 5. Over-the-counter painkillers can turn a routine day into an emergency. The combination of an ACE inhibitor, or an ARB, plus a water pill, plus ibuprofen or naproxen is called the triple whammy in the medical literature, and it raises the risk of acute kidney injury by roughly 31% compared to the same 2 blood pressure medications without the painkiller. Advil is ibuprofen. Motrin is ibuprofen. Aleve is naproxen. Older adults on multiple medications are the primary victims. The painkiller is over-the-counter, so it does not feel like a real drug. It is. Acetaminophen, Tylenol, is generally the safer choice for occasional pain in this population, but always run it past your doctor. Number 4. Kidney disease, at the stage that matters most, has no pain. The kidney has no pain fibers inside the filtering tissue itself. A kidney can be losing function for a decade, protein leaking, mesh scarring, filtering capacity dropping, and produce 0 warning signal you can feel. No ache, no twinge, no tenderness in the lower back. By the time symptoms do appear, swelling in the ankles, fatigue that will not lift, nausea, itching, foam that has been there for years, the damage is typically well past the early stage where the most effective interventions work. This is the piece that catches people off guard. The organ that filters your entire blood volume roughly 40 times a day gives you almost no early warning that anything is wrong. That is exactly why the urine test at number 1 matters so much. It is your early warning system, because your body will not give you one. Number 3. All 3 drugs lower blood pressure. Only 2 of them defend the filter. Lisinopril and losartan release pressure inside the kidney's filter. Amlodipine mostly lowers pressure everywhere else in the body. That difference does not mean amlodipine is a bad drug. It means that if you are on amlodipine alone, without an ACE inhibitor or an ARB alongside it, and without a urine albumin test ever ordered, the filter is not being monitored the way the mechanism of your medication requires. Number 2. If your creatinine went up when you started an ACE inhibitor, do not panic and do not stop the drug on your own. A rise of up to 30% in the first 2 months is what the drug is supposed to do. It is the signature of pressure inside the filter coming down. Talk to your doctor. Discontinuing a working ACE inhibitor because of an expected creatinine bump is one of the most common ways patients quietly lose the very kidney protection the drug was giving them. Number 1. The one urine test that 96% of hypertensive patients have never been offered. It is called the urine albumin-to-creatinine ratio, often shortened to uACR or uACR. A single urine sample. It costs almost nothing. The 2025 American Heart Association and American College of Cardiology hypertension guidelines say every adult being treated for high blood pressure should have it done at least once a year. In the global data across 3 million patients and 44 countries, only about 4% do. Your result should be under 30 milligrams per gram. Between 30 and 300 is moderately increased albumin, historically called microalbuminuria, and it is a signal your doctor needs to know about. Above 300 is severe. If you have been on a blood pressure medication for more than a year and you have never been offered this test, that conversation is the single most valuable thing you can do at your next appointment. How old are you? Write your age in the comments. Here is why age matters. Kidney mass drops about 10% for every decade past 30. which means the older you are, the less normal a normal creatinine actually is. And the more the urine test becomes the piece that tells the truth. At 65, your kidneys are running with roughly 70% of the mass you had at 30. At 75, closer to 60. In your 80s, closer to 50. The pill does its job, but the pill alone cannot tell you what the filters look like. Only the test can. Here is what to do next. A specific, named, 5-step plan. The Kidney Silent Signal Protocol. Step 1. Ask for the uACR test at your next appointment. Not the standard basic metabolic panel. The urine albumin-to-creatinine ratio specifically. Write it down on paper if you need to. I would like the urine albumin-to-creatinine ratio test. Under 30 milligrams per gram is the safe zone. Between 30 and 300 means moderately increased albumin. Above 300 is severe and warrants a nephrology referral. Step 2. Know your medication class. Look at the label on your bottle. If it says lisinopril, ramipril, enalapril, or benazepril, you are on an ACE inhibitor. If it says losartan, valsartan, olmesartan, telmisartan, or irbesartan, you are on an ARB. Both defend the filter. If it says amlodipine, nifedipine, or felodipine, you are on a calcium channel blocker. If that is your only blood pressure medication, and you have never had a uACR, that is the highest priority conversation. Step 3. Never combine ibuprofen or naproxen with your blood pressure medication without asking. If you are also on a water pill, hydrochlorothiazide, furosemide, spironolactone, the risk multiplies. Acetaminophen is generally the safer choice for occasional pain, but talk to your doctor before making any switch. Step 4. If you have just started an ACE inhibitor or ARB, do not panic at the first creatinine rise. A rise of up to 30% in the first 2 months is the expected signature of the drug working. Stabilization at that level is associated with better long-term kidney survival. Discontinuation should be a doctor's decision, not a reaction to one number on one page. Step 5. Retest annually. The guideline says at least once a year for every hypertensive patient. If your doctor has not ordered a uACR in the last 12 months, ask. Please discuss any of these steps with your doctor before acting on them. This video is not a substitute for personalized medical advice. One more thing worth asking about. Home urine albumin test kits have been validated in published research in the last 2 years, with sensitivity above 96% in the newest smartphone read versions. They are not a replacement for lab confirmation, but they can bridge the 12-month gap between annual appointments. Ask your doctor whether one of the currently available options makes sense for your situation. 14 days from now, retest yourself with the foam check. First urination of the morning, same conditions. Post the second result underneath your first one. That is the loop. Every week, Inside Aging goes through research your doctor does not have time to explain. If that is what you want in your feed, subscribe now and hit the bell. Tomorrow morning, before you flush, look for 1 minute. If you see persistent foam, don't guess, don't wait, don't drink more water, and hope it goes away. Ask for the urine albumin-to-creatinine ratio. That one conversation could save years of kidney function. We'll see you next week.